everybody. Let me start by thanking the committee for the opportunity to speak to you today, as well as Haemonetics for allowing me to do so. My name is Dr. Babak Sarani. I am the Chief of Trauma and Acute Care Surgery at the George Washington University School of Medicine in Washington, D.C., and I'm a professor of surgery in the same medical school. Today, we're going to talk about thromboelastography specifically and its role in both trauma as well as critical care, non-trauma critical care. Specifically, what we'll do is just very quickly go over the coagulation cascade, some very, very basic physiology fairly quickly for an audience like you, and then move on to actual thromboelastography. And we'll discuss a little bit about the evidence underlying thromboelastography and its role in trauma surgery. And I'd like to end with about 5 different case scenarios showing kind of at least how we use thromboelastography at George Washington for the management of critically injured, critically ill patients. And we'll spend a little bit of time talking about platelet mapping in particular, which I think is a very unique aspect of TEG. So as you know, the coagulation cascade is quite complicated. At least in the United States, we learn it as a cascade of different coagulation factors. But in reality, that's a very simple way of looking at it. This is a much, much more complete way of looking at coagulation. And even this is really quite simplified. And you can see there are all sorts of interactions between the various clotting factors, various excitatory as well as inhibitory pathways, the platelet, the red blood cell, and these things all come together to form a platelet plug. And that's why I think a standard coagulation measure like a prothrombin time or a partial thromboplastin time, PTT, really is not sufficient as a way to assess coagulopathy, particularly in injured patients. And if you ask, well, what happens when we order a conventional coagulation test? Here's what happens. We send a specimen of blood to the laboratory. The first thing the laboratory will do if they want to give you the PT or PTT test result is they will centrifuge the specimen for about 15 minutes. And they will then take off the top layer of the specimen, the plasma, and they will run the test on the plasma. And really what they're telling you is if your patient was made of plasma, here's what would happen. But of course, that doesn't make any sense because as I mentioned just now, the coagulation cascade and the clots are quite complicated, and it's much, much more complicated than just the nature of the plasma. This test, the PT-PTT, makes sense if we have altered the plasma. So if we've given the patient warfarin, or if we've given the person heparin, and we want to ask how much have we altered the plasma, then these tests make a lot of sense. But if someone has been severely injured, then in reality, this test is an insufficient way of measuring coagulopathy. In addition, the tests, the conventional tests, do not account for the platelet contribution, right? And we all know that platelet number and platelet function are 2 very different things. Whereas thromboelastography allows us to measure platelet activity or platelet function. And as we'll talk about when we get to platelet mapping, we can even talk about the impact of inhibitors like clopidogrel or other ADP pathway inhibitors, as well as aspirin on the function of the platelet itself. So really, if you think about it, a standard coagulation measure, a PT-PTT, prothrombin and partial thromboplastin time, or a platelet count onto itself is really an insufficient way of measuring clotting ability in the injured patient. I want to show you some data to back up what I just said. And so when you start comparing conventional coagulation tests with thromboelastography, here's what you find. As you mentioned before, the conventional tests are based on the serum alone, whereas a TEG is based on a whole blood. It does take into account the contribution of the red blood cell. It does take into account the various factors that have to come together to form an actual clot. PT-PTT takes a minimum of 30 minutes because 15 minutes is spent centrifuging alone. Whereas with TEG, particularly in the new TEG 6S system, is more of a point of care, almost a bedside type of test, where you can get a real-time answer in very few minutes. And you can kind of see the differences between the 2 modalities otherwise as shown on this slide. And we already talked about how conventional measures do not account for the contribution of the platelet, whereas TEG does. And one of the slides I want to talk about in a few minutes from now will be fibrinolysis. And that is a key point that differentiates viscoelastography, particularly TEG, from standard measures. It's one thing to say, my patient is able to form a clot. That's great. The question is your patient able to keep that clot and able to stabilize that clot? Who should get an antifibrinolytic agent such as tranexamic acid, and who should not get TXA? And those are the types of things we can talk about when we get down to TEG. I think you already know that TEG has been around for a very long time. Initially, the older machine is the TEG 5000. That's the one you see in the upper left-hand side. A little bit easier to understand because it's much more manual. Whereas the newer generation is the TEG 6S. A little bit more difficult to understand, almost like magic, I think. It's more of a cartridge-based system, but it's much less manual. It's almost like an automatic point of care at the bedside test. So let's talk about how this thing is even done. So if you go back to the original system, the TEG 5000, what basically happens is this. We draw some blood and we send it down to the laboratory. This time, the laboratory technologist will not centrifuge the blood and take out the top. They're going to take a specimen of the whole blood. And they'll take that specimen, they'll put it inside a cup, much like this. The cup then is suspended inside this machine, and there's a pin that sits in the middle of the cup. The cup starts to turn to allow all of the various components of the blood to mix. And as the components of the blood mix, a clot is formed. That clot then grabs the pin, and the pin starts to turn. So we can now create a graph. And on the x-axis, what you see basically is time. On the y-axis, think of y-axis as clot strength. Just kind of think of it that way. And we can now look at the different aspects of clot formation. The time it takes from when we first start the machine going to when the very first clot forms is called the R time. And the R time is mostly a manifestation of your coagulation factors. If you remember that the factors are enzymes that speed up reactions, then if the R time gets longer and longer and longer, that means that the reaction is going slower and slower and slower. And basically the patient needs coagulation factors. In our world, we would give the person plasma, which has all the coagulation factors. Looking again at the 5000 system, the next variable that I tend to look at is the alpha angle. The alpha angle is really a demonstration of the strength of the clot when it first is formed. When the clot first grabs the pin, with what strength does it grab the pin? Remember that the y-axis is clot strength. And really, this is a manifestation of factors 2 and factor 1, thrombin and fibrinogen, coming together to form a clot. If the alpha angle is shallow, that means we do not have much strength. That means that our patient, more often than not, needs fibrinogen. They are hypofibrinogenemic. You can give them either concentrated fibrinogen, or you can give them cryoprecipitate. And then the next variable we look at George Washington is the MA, the maximum amplitude. This is the maximum clot strength. The maximum clot strength is made up 80% by the platelet and about 20% by fibrin. So if the MA is down just a little bit, we oftentimes will give the person cryoprecipitate or fibrinogen concentrate. But if the MA is significantly down, 80% down, then we're going to start talking about giving the person a platelet transfusion. And last and not least, certainly, but quite unique to TEG, is the back here, where you can see this number called the LY or the LY30. And this is the degree of clot lysis at 30 minutes. So if you look at the graph, here we had a patient, clot finally formed at the end of the R time. The strength was this, depicted as the alpha angle. The maximum strength was here at the MA, so the clot was doing great. But look, after about 20 minutes, all of a sudden, the clot loses strength again. And the reason it's losing strength is that the clot is dissolving and no longer grabbing that pin to allow it to turn. For this particular patient, what we need to give them is an antifibrinolytic agent to stabilize the clot that had already formed. What they need is tranexamic acid. That is the old system. In the new system, you don't have to worry about all those details. Rather, what you get is a cartridge that looks kind of like this. A specimen of blood goes into the cartridge, and then the machine will run 4 tests at the exact same time, and it'll give you different variables. And I'll kind of show you some of those in the cases that we discuss. But basically what the 6S does is it takes a machine that really is difficult to use, that lives mostly in the laboratory, and makes it easier, automatic, and faster because it's going to run all the tests at the same time and start giving you information at the same time. The one big difference between the 6S and the 5000 is some of the words. And the biggest difference that you have to remember is that the alpha angle no longer exists. There will be no such thing called alpha angle in the 6S. That will be called the CFF, which really stands for functional fibrinogen. That's going to tell you very directly what the fibrinogen contribution is to the clot and whether or not you have to give the person fibrinogen concentrate or cryoprecipitate. And I'll show you some of these examples when we get to the case studies. Couple of articles I want to go over fairly briefly. These are two really great articles that basically say the same thing. They suggest pretty strongly that a TEG-directed resuscitation is superior to a blind balanced resuscitation. Now, I know most of the people listening to this talk are trauma surgeons, and I suspect all of us are now very familiar with the concept of a 1-to-1-to-1 resuscitation. Red blood cell, plasma, platelet, 1-to-1-to-1, balanced resuscitation. If you look down at this second article, which I really enjoy, this Journal of Trauma and Acute Care Surgery article by Dr. Maddox and his colleagues down in Texas. This article, the background to the article is basically this. Before 1-to-1-to-1 was really became the standard of care, the people at Texas were using TEG. And when the American College of Surgeons came by and said, well, everybody really should use a 1-to-1-to-1, that's the new standard, they did a study. And what they did is they compared TEG-directed resuscitation to just a continuous 1-to-1-to-1. And what they found was that a TEG-directed resuscitation was associated with lower overall transfusion need and lower mortality as compared to a 1-to-1-to-1. And this next article says the same thing. Here in the red line, what you see is mortality, survival. If you have a TEG-directed resuscitation as compared to survival if you use conventional coagulation measures and a 1-to-1 resuscitation in critically injured patients. And what you see now is that there's a significant benefit to using a TEG-directed. So what do we do here at GW? We kind of do a little bit of both, because I don't think you can get by without doing a 1-to-1 resuscitation. You have to start somewhere. And so what we tend to do is we will start with a standard 1-to-1-to-1 paradigm, and then we will order serial TEGs and adjust that to the TEG. And I'll show you some examples of that. So our protocol at GW does not include cryoprecipitate, for example. It's only plasma, either whole blood or packed red blood cells, and platelets. But if we find that the CFF is low, or if we find that the alpha angle is low, we will give the patient cryoprecipitate. Similarly, we will 100% give TXA after 3 hours. We'll give TXA 5 hours after injury, regardless of what the CRASH 2 study said, if we see that the LY30 is going up, because now we're doing a directed resuscitation and we're not just giving it blindly like the CRASH 2 study did. We know that hyperfibrinolysis, if the LY30 is elevated and that is not treated, is associated with a higher risk of death, which is why we will measure the LY30 and we will go ahead and give TXA if we find that it's elevated, regardless of the time from injury to the test result. Everyone knows the CRASH 2 study. It showed a mortality benefit, particularly bleeding-related mortality benefit in patients who were severely injured and either bleeding or at risk of bleeding and received TXA. This was, as you know, a very, very big deal. It was published in The Lancet. It's one of the largest studies ever done in trauma surgery. That concept of give TXA was further validated in the MATTERS 1 and MATTERS 2 trials, where a retrospective evaluation of people who were soldiers who were injured in Iraq and Afghanistan was done. And as you can see over here, the survival rate was higher in patients who were severely injured and received TXA, and was higher even still if you were severely injured to the point where you required a massive transfusion and you received TXA. But remember that, at least in the CRASH 2 trial, the data also said you're not supposed to give TXA if the time from injury to TXA is more than 3 hours. They found that there was an increase in mortality if you receive TXA more than 3 hours following injury. But I would suggest to you that that's not always true. That's true if you're blindly dosing the drug, which is what happened in CRASH 1. I'm sorry, what happened in CRASH 2. Now, what happened in Matters 1 and Matters 2? They were given the drug blindly. They were not using TEGs. We give the drug in a directed fashion. And so we are, in my opinion, treating a laboratory test that we need to know about and that will result in worsening, bleeding, and potentially death if we don't treat it. On the other hand, if we treat everybody, you're at risk of developing this problem. Here's a study done from the Denver group, Dr. Gene Moore and his colleagues at Denver Health. And they basically took patients who were severely injured and identified 3 different groups. In the green group, you see people who've shown up and their LY30 is almost 0. It's less than 0.8%. And in the red group, you see people who've shown up and their LY30 is significantly elevated. It's more than 3%. And what the article basically says is, if you give TXA to people in the green group, the mortality goes up. But if you don't give TXA to people in the red group, their mortality also goes up. So it's not as easy as giving the drug blindly. We need to know where these patients fall and then dose the drug appropriately. And I have certainly seen plenty of people in my trauma center who were severely, severely injured, bleeding to death from a variety of mechanisms, but their LY30 is actually 0. And I would argue if we had given those people TXA, they would have fallen into this green group and the mortality may have worsened. And I've certainly seen plenty of people who fall in the red group, and we need to give them TXA because you will find that they are in fact bleeding. And so the protocol at George Washington is something like this. We will get a TEG on arrival to the trauma center as an automatic test for our priority 1 traumas. If the LY30 is more than about 3%, we will go ahead and give them tranexamic acid, regardless of the amount of time that's gone by from injury. If the LY30 is less than about 1%, we will not give them TXA. And if it's somewhere in the middle, we'll probably just do nothing and retest them. Once in a while, they drop to less than 1%. Once in a while, they go more than 3%, and then we'll just dose them appropriately. So we get a number of TEGs in a row to try to plot the patient out and determine which way they're going. So that's the first part of the talk about the coagulation cascade. What about the platelet itself, however? Can we utilize thromboelastography as a way to measure platelet function? And the short answer is yes, we can. We probably should. But there are nuances that we have to understand. As you know, there are plenty of articles out there that say if you're on aspirin, if you're on clopidogrel and you're injured, you will do worse. There are also articles out there that say it doesn't matter whether you're on aspirin or clopidogrel, that doesn't impact outcome. So you can choose any article you like. But realistically speaking, when someone comes into your hospital and they're on these drugs and they have a subarachnoid bleed or a subdural bleed, this is very common, you need to ask, what am I going to do? And we need an answer for that question. So we sought out to try to answer this. We took all the patients that came to GW who were injured, and we got a TEG platelet map on them. And what you can see over here is the degree of inhibition noted. Mind you, nobody in this study was on either clopidogrel or aspirin. We made sure of that. And yet you find that everybody shows up with a pretty significant degree of inhibition at the baseline. Now, there were not that many people who had adenosine diphosphate inhibitors, and there were not that many people on clopidogrel. However, there was a significant number of people on arachidonic acid inhibitors, which is aspirin. So I think we can talk a lot about aspirin. We may not be able to speak as much about clopidogrel because the number of people in the study on clopidogrel was low. But what you can see is despite the fact that the average injury severity score of the patients in this study was 7. The average injury severity score of patients in this study was 7. Very, very low injury severity score. And yet you find that about they have an average degree of inhibition of 30%. And whether they had brain injury or didn't have brain injury really didn't alter the outcome at all. Same is true of the ADP pathway. So the first lesson to remember, if you're going to order a TEG platelet map, is that there's a degree of baseline inhibition that you cannot overcome. This is normal. So we can give the person platelets, but you're not going to drop below 30% inhibition. That's the baseline. We then said, okay, what if somebody is on aspirin or Plavix? And we compared people not on aspirin and Plavix to people on aspirin and Plavix. And what you can see is absolutely, of course, the drug works. You can see in the aspirin pathway, percent inhibition went from 30% to 50% because they were taking a drug that inhibits that pathway. The ADP pathway, again, I do not make too many comments about, and that's because the number of people on that pathway was very, very small in the study. And then we said, okay, we understand that the baseline inhibition is about 30%, but if you're taking the medication, it'll be higher. Medication does work. What if you give them platelets? Does the platelet transfusion have any impact on at least platelet function as measured by TEG? And the answer is yes. You can go from about 54% inhibition down back to 30% inhibition. That's a statistically significant difference by giving them a platelet transfusion. But we did not find any dose-response relationship. So giving 2 units of platelets is no better than giving 1 unit of platelet. We didn't find a relationship. What I would suggest we should do is for people who have severe traumatic brain injury, you're worried about them, they're on aspirin, go ahead and give them a dose of platelets and then recheck the TEG. And if you need to give another dose, do that and then recheck the TEG. You'll find that at some level, you're going to plateau and giving that person more platelets is not useful anymore. And that's how we do it here. So we talked about baseline inhibition. We talked about the impact of aspirin on baseline inhibition. We talked about platelet transfusion as a way to reverse that. But the next question is, does it matter? I mean, should we be doing this? And at least in our study, we did another study here. You can see the numbers are kind of getting smaller and smaller. But in this study, people were on aspirin. They did get platelet transfused. If you look here under pre-transfusion, post-transfusion, in fact, that did work. They went from 76% inhibited down to 50% inhibited. That was a significant difference. Even in the clopidogrel pathway, there was a difference, although that didn't hit significance because, again, the number is small. And yet there was no difference in outcome whatsoever. There was no difference in either the severity of the brain bleed as measured on the repeat head CT. There was no difference in Glasgow Coma score, no difference in mortality, no difference in outcome. So yes, giving a platelet transfusion does reverse. Does it actually matter? Nobody knows. And I think the study is a bit too small. It was unfortunately never repeated, and that we're left with this. So in my hands, if somebody shows up and they have a significant subarachnoid bleed after a fall on aspirin, we will go ahead and give them a single dose of platelets as a way to reverse that. I just can't tell you hands down that that actually matters in terms of their overall outcome. And then just a little bit more before we switch over to actual cases, we went to the medical intensive care unit. These are no longer surgical patients. These are now medical patients. And we asked the same thing. Namely, if you give these people platelets, what happens? Namely, we asked, what is the degree of baseline inhibition in this cohort? And you can see, once again, we found a pretty significant degree of inhibition, about 46 or so% overall from just being medically critically ill. And if they're on an antiplatelet agent, obviously it got even more inhibited. So the bottom line is the outcomes and the findings in the medical intensive care unit are the same ones as the surgical intensive care unit. And there seems to be a phenomenon where people develop platelet dysfunction when they are severely ill, whether it's medically ill, pneumonia, things like that, or surgically ill, traumatically injured, things like that. So no difference in outcomes, no difference in processes. With that in mind, let me switch over to a few cases and show you essentially how we use thromboelastography here in the trauma center. This first case is about a 45-year-old gentleman who was hit by a car twice. The person was run over by a car and the person backed over the person again. Comes to the trauma center with a crushed chest, crushed pelvis, very unstable, cardiac arrested, underwent a resuscitative left thoracotomy with clamping of the aorta, and then was taken to the operating room for essentially chest wall reconstruction and pelvic fixation. He survived to discharge. But look at the thromboelastogram that was obtained. This is now several years ago. We're using the TEG 5000 system, and you can see some of these names like alpha angle, for example. But if you look over here, the R time, you can see the R time is 15 minutes long. The upper limit of normal is 8. Clearly, this person is severely coagulopathic and needs plasma. In addition, the alpha angle looks very shallow. When you look down here, the alpha angle is about 20 degrees. Normal lower limit is 55 degrees. So this person is also severely hypofibrinogenemic and is not really able to make clot. This person needs cryoprecipitate or fibrinogen concentrate. The maximum amplitude is very low. Normal is about 51. This is 23. The person is going to have either severe thrombocytopenia or extremely severe platelet dysfunction, despite a potentially normal platelet count, person needs a platelet transfusion. And so far, so good. You could argue, so why you haven't told me anything I don't already know? I would have given this person a balanced transfusion. I would give them FFP, I would give them red blood cells, and I would give them platelets. And I agree with you there. You may not give them cryoprecipitate, however, and I think in this curve, most importantly, is the LY30, which is basically 100%. This person absolutely needs to get tranexamic acid. And you can now see how we are utilizing the TEG as a way to customize the resuscitation. We start with a 1-to-1 and we move forward to other elements like fibrinogen concentrates and TXA. This next curve is a young woman who tried to commit suicide by jumping off of I think an 8-story building. The only reason she's alive is on the way down, she hit multiple different tree branches that slowed her rate of descent until she finally hit the ground. She presented with all extremities broken, pelvis severely broken, very unstable bleeding into her pelvis. But look at her TEG result. It's amazing how hypercoagulable she initially is. First of all, the R time is completely normal. So yes, we're going to give her the 1-to-1 transfusion because she's unstable, having fallen 8 stories. But right now anyway, she doesn't actually need the plasma. If you look at the alpha angle, it is incredibly broad. It's bordering the upper limit of normal, 76%, 76 degrees instead of 78 degrees. She does not need cryoprecipitate. Even the maximum amplitude is 70 millimeters, upper limit is 69. This woman is hypercoagulable. Now she's bleeding. Sooner or later, she will become hypocoagulable. That is a true statement. But look at what's happening to the LY30 as it's coming down. What she really needs is tranexamic acid to stop the bleeding as fast as possible and try to prevent her from going into the hypocoagulable phase of the bleed. And once again, the elements of thromboelastography that help us determine that. More recently, about a few months ago, we had an 80-year-old male, fell down a number of stairs in his house, presents with a blood pressure 132/90, heart rate of 130, respiratory rate of 20, and about 99% oxygen saturation on face mask. GCS score is 6, as you can see. On CT scan, the person has a grade 4, maybe grade 5, splenic laceration with active bleeding. He also has a subarachnoid bleed and a subdural bleed. Luckily, those are fairly small. Patient is now intubated because of brain injury. Oh, by the way, the person is on apixaban. He fell many hours prior to presentation, so we went ahead and reversed the apixaban with 4-factor prothrombin complex concentrate, which in the United States is a drug called Kcentra. In Europe, it's called Beriplex. I'm not quite sure what it's called in South America, but we gave the person 4-factor PCC to reverse him. And here's your initial tests. So there's the hemoglobin, 10.5 grams per deciliter. You can see the INR is 1.5. The R time is normal, but the CFF, the functional fibrinogen, is low. And the maximum amplitude is low. LY30 is 0. If all you got was PT, PTT, INR, you would think things are just fine. But things are actually not fine at all. The person is low on fibrinogen and with a grade 5 splenic injury and a traumatic brain injury. So this is one of the first times where you can say to yourself, well, wait a second, maybe this person does not need a massive transfusion, but he does need to have the fibrinogen repleted and the platelets are dysfunctional. We probably should consider giving the person a platelet transfusion. And so my question for the audience is, now what would you do? Given that the person is coagulopathic, would you take him for splenectomy or would you try embolization? I will tell you that at GW, one of the younger attending staff took this person for embolization, which I think was a little bit of a mistake. And that person then ended up failing in the morning, was bleeding quite avidly. We took the person to the operating room. And at the time of operation, now look at the TEG. The R time it's completely altered. The initial R time was 6 minutes. Now it's coming up on 10 minutes. The fibrinogen activity has dropped even further. Same with the maximum amplitude. And now the LY30 is trending up. You'll recall that the LY30 on arrival was 0. Now it's about 1%. It's still less than that magical 3% cutoff, but it is trending in the wrong direction along with everything else. So the question for the audience is, during the operation, the surgeon says, I see a lot of oozing in the field. Would you guys give this person TXA? We are now well beyond 3 hours from the time of injury. We're pushing maybe 8 to 10 hours from the time of injury. And my point is, yes, I think this person should get tranexamic acid. You'll notice that all of your coagulation parameters are going in the wrong direction. And the surgeon says, I don't see any clot in the field. What I see is oozing in the field. And so the TEG is able to keep up with us and tell us in the real time where things are trending, and we can now act on that. And I think even looking back, probably at this level here, an older person on a anticoagulant with altered TEG parameters probably should have never undergone embolization in the first place, probably should have had a splenectomy on arrival. Next quick case I want to show you guys is a 27-year-old gunshot wound to the right iliac vein and the inferior vena cava. Presents very unstable. Initial blood pressure is about 80/40, heart rate of 145, GCS score is 11. We start a massive transfusion. We give the person blood. We get a better blood pressure than we had before, and we go ahead and intubate the person. So we give a more of a CAB type of approach where we resuscitate the patient first and then we intubate. The FAST is grossly positive. We start tranexamic acid in this person up front, knowing that this is a terrible injury and we're going to be having problems with coagulopathy. And we take the person to the operating room. Now, mind you, the person arrived at 1500 hours at around 3 o'clock in the afternoon. The initial TEG is sent about an hour and a half later. And now we're in the operating room. We're trying to fix the vena cava. We're trying to fix the iliac vein. The person is bleeding very, very aggressively. And what you find over here now is that the maximum amplitude is down. That's okay. He's in a 1-to-1 resuscitation. He's going to get platelets anyway. But importantly for the anesthetist, the CFF is down. And this is the TEG 6S now reporting. Remember that CFF and alpha angle are basically the same thing. This is telling the anesthetist that the person needs to receive fibrinogen, whether you want to give fibrinogen concentrate or in our world, we would give the person cryoprecipitate. Up to you. But the lower limit of CFF is 15. This patient's level is 5. This person is not going to be able to form any clot, no matter how much you try to suture those veins. And so we go ahead and give the person cryoprecipitate. We get another TEG measure about an hour and a half later, and you can see, yes, we've made progress, but unfortunately, we need to continue. The person is still consuming their fibrinogen stores, and same thing is true of their platelet stores. Luckily, the TXA worked beautifully. The LY30 is 0. And thus far, the plasma is keeping up pretty nicely. Our R time is appropriate. Move forward again. Now we're in the intensive care unit. We've stopped the bleeding. The person has an open abdomen, but he remains very, very unstable, very acidemic. And you can see that we're now following serial TEGs at 2 o'clock in the morning. Things are looking pretty good. And so we say, all right, stop. Let's just let the person recover a little bit. We all rest. The next day, we go back to the operating room to wash out the abdomen. We had heavy packs in there. And as soon as we take the packs off, the guy just starts to bleed all over again because the suture line on the inferior vena cava disrupted. This was not a coagulopathic bleed. We know that because of the previous TEG. This was a disruption of the suture line. And so unfortunately, we're back to square one with a person bleeding very aggressively. And we, once again, start doing the same thing we always do, a 1-to-1 resuscitation. We get the next thromboelastogram. And now look at what's happened. He is physiologically exhausted. His R time is now 17 minutes long. Upper limit is 9. His CFF is dropping again. His maximum amplitude is dropping again. And so we're back to square one, giving the person a very aggressive resuscitation. This time, we're concentrating more and more on the R time. And I would argue in a situation like this, I would personally give the person, again, prothrombic complex concentrate. I would give him concentrated factors because the machine is telling me what the problem is. The problem right now is more on the coagulation cascade than it is on the other variables. A little bit different than it was yesterday. But either way, the person is not going to make any clot until I recover all these problems. And that's how the TEG can help us guide. Next case is a 40-year-old female who was involved in a high-speed motor vehicle crash. Comes in with a grade 5 spleen. We take out the spleen, grade 3 liver, all these broken ribs with a pneumothorax. She has a descending thoracic aortic transection, undergoes emergency stenting of the aorta on arrival. She's got a severe pelvic fracture and lumbar fracture. So all these issues. Comes in, we start a 1-to-1-to-1, we go direct to the OR, we take out the spleen, we pack the liver, we go to the hybrid operating room, we put a stent in the aorta. Things are moving along very well. And you would think that this person kind of just should settle out and do okay. Person goes to the intensive care unit. I go see the person about 6 hours later. And all of a sudden, 6 hours later, we see a lot of variation in the arterial line. Lot of variation in the arterial line. And the pulse pressure suggests severe hypovolemia. Person has been started on norepinephrine, was given too much crystalloid by the anesthesiologists, unfortunately, so there's a dilutional component here, and we get some conventional coags that come back like this. The PT time is 14.6 minutes, the INR is 1.3, prothrombin time is elevated to about 90, but the platelet count's okay. And so what would you do? I think most of us for this would probably do not a whole lot, maybe give a little bit of plasma and that's about it. But there's nothing here that tells you exactly what's wrong until you get the TEG. So we get the TEG, and now using the TEG 5000 system, the R time is unbelievably elevated. And you can see that the alpha angle is very, very low. So this person is lacking coagulation factors much more than would be predicted based on the coagulation, conventional coagulation tests. And the alpha angle is depressed, suggesting that the person again needs fibrinogen concentrate. And so this person gets FFP and cryoprecipitate to resuscitate them. And without the use of a TEG, you simply would not know to give all these agents. You can get a fibrinogen test and all the other tests and try to piece it together. But the benefit of TEG is it gives it all to you in one shot in the real time and kind of know which way to go. So that's essentially the use of thromboelastography at George Washington. What we do is we get a TEG on arrival for all of our priority 1 highest level trauma activations. We will start with a 1-to-1-to-1, but then we'll customize it to the patient based on the thromboelastogram. Nowadays, we also get it on people who have gastrointestinal bleeding or any other form of bleeding for that matter. We've become very used to this, and we kind of think that utilization of the TEG to direct the resuscitation is a more effective way to go than just a blind 1-to-1-to-1. And lastly, about patients who have traumatic brain injury and are on aspirin, we will go ahead and get the TEG, knowing that we may want to give platelets in select instances, depending on the severity of the brain injury. That's my talk. Thank you again for your patience, and thank you to the committee for allowing me to speak. It's been a pleasure. Thank you.
So thanks very much. From our part also, Dr. Babak Sarani. My name is Ludwig Albornoz. I'm the Chief of Pathology and Lab Medicine at our institution. Very pleased to meet you and have us with us. Thank you for your presentation. I'm going to do a little housekeeping announcement for our interpreter so he knows how we go forward. Oscar, yo voy a leer las preguntas al doctor y luego usted puede, por favor, hacer la interpretación simultánea, la traducción simultánea de las respuestas del doctor. ¿De acuerdo? Oscar, ¿en línea?
Sí, señor, en línea.
Perfecto. Okay, good. Okay, good. So, thanks again, Doctor. I'm looking for the questions in the chat, and I see the following issues. There is a tendency to use viscoelastic assays outside of the laboratory much more frequently than in the lab. However, and it makes a lot of sense. It's where it's needed. You don't need to take that time to move specimens around and then have them tested and then have them somehow transmitted or seen online remotely and the like. In our case, with the current technology we have, which is the same you have shown, there was a lot of issues on being competent for the staff at the surgical suites to use these instruments. There was interference by even vibration. So it turned out that we had to bring them to the lab and have them, at least be run in a trustworthy manner and something that could be useful for our anesthesiologists and surgeons. The question is did you have an experience with your systems in which you could at all use it centrally and have the image being sent like on real-time basis? Thank you.
Well, thank you. Firstly, thank you for the opportunity to be here, and thank you for
Muchas
that
gracias por
question.
la oportunidad de estar aquí.
So our TEG 5000 system is in the central lab. It has never been at the bedside. For the exact
Nuestro,
you mentioned.
nuestro equipo del T5000 está en nuestro laboratorio central.
The machine is very vibration sensitive and is very technical. So it really is not a good machine, in my opinion, for a bedside point of care test.
En mi opinión, la máquina tiene muchas vibraciones y no es muy técnica usarla como máquina de cabecera.
When we first got the machine and we did not have the software to view the results remotely in the real time, we had the same problems you just mentioned.
Cuando obtuvimos la máquina por primera vez, nos dimos cuenta que el software no estaba capacitado para hacer los exámenes apropiados en tiempo real.
Specifically, the problem was we would send the specimen to the lab and it took so long for their results to come back. The lab would not release the results until the entire test was done. That can take about 45 minutes.
Especialmente porque teníamos que enviar las muestras al laboratorio y el laboratorio tomaba tiempo y usualmente tomaba entre 40 y 45 minutos para obtener el resultado real por parte del laboratorio.
And because of that, people simply stopped ordering it. We got around that. Go ahead.
Y por esa razón paramos de usar el sistema de laboratorio por el tiempo que estaba tomando.
We resolved that problem by getting the remote software. Now we can see the results of the TEG as it develops, very similar to an EKG.
Por esa razón, entonces, que es que el software ahora nos está entregando los resultados inmediatamente y les podemos dar un uso más apropiado, así tal como se hace con un electrocardiograma.
And the next problem was we needed to fix the computer because it initially required a different login password, and that became very difficult. So now we have a system where we only have one password to get into the medical record, and that same password gets us into the tech software.
También otro de los problemas que habíamos visto era que se necesitaban diferentes contraseñas para entrar a las diferentes partes del sistema, y por eso ahora hemos unificado y solamente usamos una sola contraseña donde nos dice la historia médica, los resultados del paciente, y así aceleramos el proceso.
And with that, people started using it again because I think everyone believes that the information is useful, but we have to make it easy for the people to get the information.
Y por eso creemos que la gente ahora cree que la información es mucho más útil, y por eso pensamos que para la gente es más conveniente porque obtienen la información al momento.
That's very clear. Thank you. And I'm going to take about 30 seconds to repeat the question I said in Spanish so that the audience can understand what we're talking about. I'm so sorry. I neglected to do that. So, para el grupo de audiencia hispanoparlante, la pregunta que le formulé al doctor tenía que ver con un aspecto técnico que nosotros hemos estado viviendo en nuestra institución, y es el hecho de que el equipo mencionado en la charla es muy sensible a la vibración y a problemas técnicos de uso que no fueron dominados a la perfección en quirófano. Entonces se trasladó al laboratorio central, lo cual introduce unas nuevas variables como son traslado de espécimen y una información que no está al lado del sitio, en el sitio de atención del paciente. Entonces hay que lograr transmisión en línea, y ustedes vieron las respuestas. La transmisión en línea tenía que ocurrir en tiempo real y los problemas de acceso de contraseñas se resolvieron. Thank you, Doctor. I must say we are experiencing right now what you're saying, but without the solution you just mentioned. So right now, doctors are missing out on the solution because they don't remember the password. So So it's exactly the same. It's amazing how humans can be so alike in distant places. So we will propose that solution and give you credit entirely for it. Entonces le digo que gracias por la solución porque nosotros estamos enfrentando ese problema y efectivamente de que la contraseña coincida para entrar a un sistema que sea la misma contraseña que trajinan en el día a día, pues suena tan obvio que me da pena no haberlo hecho antes. So thanks for that. There's another question regarding the following. It seems like, of course, viscoelastic testing does provide the physician, the surgeon, the anesthesiologist a tool to fine-tune whatever is needed to compensate the patient that is lacking on both blood and a functional coagulation system. However, interestingly, we have a protocol that has been put forth locally here to go back to something that used to be, and that is whole blood transfusion. So, because it makes sense that if you're losing whole blood, why not put back the same thing as long as it's functional? And we actually have seen that this research group locally here in our institution has had good characterization of that blood product as a whole blood in several parameters, including viscoelastic functionality. However, I wanted to know if you have any thoughts on that approach and how that articulates with your experience.
Do you want to translate that to Spanish first?
No, no sé si Oscar quiera hacer la traducción o yo me permito hacerla. Quiero decir, gracias al grupo de la fundación y de Doquier, que tenemos un protocolo en donde, un ensayo clínico controlado en donde se está abordando el uso de la transfusión de sangre completa, sangre total, y no de componentes separados. Y lo cual tiene sentido porque se pierde sangre total, se repone sangre total. Y hemos caracterizado su funcionalidad proteínica y funcional, incluso viscoelástica, interesantemente bien. Entonces, le pregunté al doctor si tiene experiencia al respecto. Please.
So we also are increasingly using whole blood, and I think there is increasing studies showing that whole blood is better than component therapy for stopping bleeding.
En este momento estamos usando el método de transfusión completa porque es mucho más práctico, es más saludable para el paciente y vemos que de esta manera podemos parar la hemorragia de una manera más efectiva y rápida.
But there are two challenges. One
Pero
is
existen dos retos. El uno es
we don't have enough whole blood to go for an entire resuscitation. At any given time, most trauma centers in the United States will give somewhere between 2 and maybe up to 8 units of whole blood, and that's all they have.
Okay, uno de los retos es que no tenemos suficiente sangre, por ejemplo, para hacer la transfusión completa. Y en los Estados Unidos, por ejemplo, lo máximo que dan es entre 2 y 8 unidades, dependiendo del caso.
De sangre total.
So if we have a patient who needs, let's say, 25 units of blood or perhaps 30 units of blood, we just don't have enough whole blood. We will have to go back to a 1-to-1-to-1 resuscitation.
Por esa razón, que no tenemos suficiente sangre, que son entre 20 y 25 unidades, por esa razón es que tenemos que volver al procedimiento de 1-a-1 reanimación.
And the second issue is we don't know if whole blood alone is sufficient or if we still need the TEG to tell us to add specific factors even with whole blood being transfused.
El otro reto es que no sabemos si la sangre completa tiene los suficientes elementos para hacer la transfusión o por esa razón en el examen del TEG nos puede decir qué más elementos podemos adicionar para que el tratamiento sea completamente eficaz.
Because remember that plasma does have fibrinogen in it. The problem is the body is using up the fibrinogen faster than you can give, because although plasma has fibrinogen, it doesn't have a lot. And so you have to give it concentration. Is that true of whole blood or not? Nobody knows.
En este caso podemos dar plasma, pero no sabemos, pero sabemos que la plasma no contiene toda la cantidad adecuada de fibrinógenos, y por esa razón no sabemos exactamente si la plasma nos va a ayudar a salir adelante en el proceso, porque sencillamente tenemos que sabemos que la plasma no está completamente concentrada, y eso es lo que hace que el reto sea inclusive mucho más grande.
And then lastly, let's not forget the LY30, is even with the presence of whole blood, we will not know who really should or should not get tranexamic acid. So I think there's still a pivotal role for TEG, even with people who are receiving whole blood.
También con la medición del LY30, podemos saber también si toda la concentración de la sangre entera es suficiente o no es suficiente durante el proceso de transfusión que debemos hacer.
Y el uso del ácido tranexamámico, exacto.
Del uso del ácido tranexamámico también.
Perfect. Very good. Very good. I want to ask the audience to see if there's another question. In fact, we have one. I'm going to say it in Spanish first. Sabemos que la hipotermia altera la función plaquetaria. Una muestra para viscoelásticas tomado de un paciente hipotérmico exhibe una disminución del MA, y si es así, ¿cómo enfoca a estos pacientes para corregir un MA bajo? ¿Dar plaquetas tempranamente o subir la temperatura? Ambas cosas. Que muchas gracias. So I'm going to go to English. We know that hypothermia alters platelet function. Does a TEG sample taken from a hypothermic patient exhibit decreased MA? And if so, what is your approach in these patients to correct low MA? Give platelets early, rewarm, both? Many thanks.
That's a fantastic question. And the answer is yes. A TEG can be run at actual body temperature as opposed to corrected temperature.
Ok, esa es una buena pregunta, porque podemos decir que el TEG se puede hacer de acuerdo a la temperatura adecuada del paciente, nos puede dar un resultado más preciso, y ahí adelante podemos ver cuál es el paso que debemos seguir.
I think if I saw a patient who was bleeding and their MA was low because they were hypothermic, but I knew that their platelet count itself is normal, I probably would start first by active rewarming as opposed to transfusion.
Si vemos un paciente donde vemos que la MA está muy abajo porque el paciente está frío, está con temperatura baja, sencillamente lo que tenemos que hacer es saber cómo le damos más temperatura al paciente, a ver si hay alguna reacción o no existe reacción por parte del paciente.
En cambio de transfundir. Yes, very clear.
En cambio de hacer la transfusión.
Thank you. Thank you. Let me see if there's anything else on the chart. On the chat, no, I do not. So I do want to proceed and let you go back to work. And thank you very much. I am very glad that you gave us a couple of pointers on how to use better the system remotely with what you have just said, and also be able to in fact know about the interesting prospects of using, at least partially, getting a hold of whole blood as a therapeutic approach. But unfortunately, here it is also even for the trial itself, it's been difficult to get enough to be able to accept a single patient, let alone a normal trauma center dynamics. Thank you very much.
Thank you very
Gracias,
much.
muchas gracias para todos.